Bill Gradishar, professor of medicine at Northwestern University, where I am also chief of hematology oncology. In patients with early stage disease, we used to approach our recommendations for therapy in a relatively crude way. And that is that if you had invasive disease of a certain dimension, you are almost uniformly going to get chemotherapy. And the younger the patient was, the more likely that recommendation would be made very strongly. Similarly, if you have ER positive or hormone sensitive breast cancer, then and now it's a pretty uniform recommendation to receive anti-hormone therapy. So in the last 25 years, we've refined our different treatments, the recipes of chemotherapy have changed, endocrine therapy, we've added some additional drugs, we refine how we use them and for how long. But the question of who should get it was really altered by the introduction of molecular tests that, in a sense, look below the hood. And by that, I mean, we often relied on the size of the tumor, the number of nodes, and the other features such as hormone sensitivity, HER2 status. And those elements alone would inform our decision about whether or not a patient should get chemotherapy, in addition to anti-hormone therapy if they were hormone sensitive breast cancer. Now, really over the last 15, maybe almost now approaching 20 years, we've seen the introduction of molecular tests that on a more granular level start to look at the drivers of an individual tumor. So in addition to the clinical features I talked about, in patients with hormone-sensitive breast cancer, we very commonly, particularly in node-negative patients, will order one of these tests to help inform whether or not chemotherapy is necessary or it could be avoided. And we've recognized for decades that many of the patients we treat with chemotherapy probably don't need it. We weren't trying to be mean or abusive. We simply didn't have the tools available to figure out who it was that can avoid chemotherapy. So these molecular tools, such as the recurrence score or the MammaPrint test, are genomic assays that clarify for many patients whether there's really a need for chemotherapy or not. And that was pretty convincingly demonstrated in node-negative disease, and more recently in patients with low node positive disease, meaning relatively few positive lymph nodes. There are subsets of patients based on the results of those tests where we feel very comfortable saying anti-hormone therapy alone is all you should get. Chemotherapy can be avoided. And similarly, we can very convincingly tell certain patients that anti-hormone therapy is insufficient in order to really optimize your risk reduction and avoid a recurrence in the future. Chemotherapy should be part of the plan. So these tools, in my mind, have refined the clinician's ability to inform the patient about the best choices for reducing the risk of ever having to deal with breast cancer again.